When I was educating this client on cognitive processing therapy for PTSD versus other approaches, what I made sure that she understood was that it is an evidence-based treatment. It's under cognitive behavioral therapy, and it's on the more cognitive side. The really important difference between cognitive processing therapy and prolonged exposure. Prolonged exposure is very powerful, but it is more distressing in the short term for patients. For a patient with a lot of avoidance and high levels of control, it's very hard to start with exposure therapy unless they're very motivated to do so. So cognitive processing therapy can be a lot more approachable. The reason why cognitive processing therapy is a little bit easier to approach for patients is because it's all about their thoughts and their interpretation about what happened. It's not necessarily that they have to go back and relive what happened. However, I personally always push prolonged exposure. And with this patient, I told her after we did cognitive processing therapy, we would do prolonged exposure. And we did end up doing that. And that really helped resolve some other symptoms just by going back to the memory. What cognitive processing therapy involves is identifying natural emotions versus manufactured emotions and start to help the patient understand the difference between the two. And what a big piece of it is stuck points. Stuck points are maladaptive thoughts that get in the way, thoughts that are fuel to the flame of PTSD. And they maintain these manufactured emotions that maintain the client's distress over time. A lot of times the client has not had time to feel the natural emotions associated with an event like sadness, loss, even some anger. So some time in cognitive processing therapy is spent on feeling the feelings that they have never had time for and that they just had to skip over. Identifying the stuck points you do through conversation. So there are some handouts that help with this. But you do this through conversation, and as a clinician, you keep your ear open to start to hear when a patient is being too hard on themselves or when they are making big global statements about other people or the world that might be really maintaining their fear. So when I'm listening for stuck points, I'm really thinking in terms of emotions. So the emotions that they struggle with, what is it that they're thinking that's attached to that? And especially as we're talking about guilt, responsibility, shame, regret here, I always have my ear open for those emotions. And I start to ask questions about how they interpret what happened. So if they say, I just feel so guilty, I say, why? What is the thought behind that? Or why do you think that you are guilty in this situation? Help me understand. Cognitive processing therapy is also based on Socratic questioning. Socratic questioning is all about sitting back and being very inquisitive and curious and asking the right questions that help you get the information and help the patient arrive to where they need to be. So as I'm asking for stuck points, I'm saying, I don't know if I fully understand that. Help me understand why you feel like you're to blame. And this is when the patient gives us more details. Stuck points have to be a little bit specific. That allows us to work with them more fully. So for example, this patient actually did tell me the details of her trauma. So she was sexually abused by her stepfather from age 8 to about age 14. And she tried to tell her mom, but her mom did nothing. Her mom was aware that it was happening. This was her biological mother, but she protected the stepdad and not her own daughter. So that was another whole layer in trauma. We know that in trauma land, when a client, a patient, a child tells their caregiver or tells somebody who's supposed to protect them, and that person does nothing. That can often be more harmful than the original trauma itself. That's a deeper wound. And so this patient did report having that. And so as she told me about the trauma and I was able to ask those questions, do you feel guilty? Why do you feel guilty? Who do you blame for this? If you feel guilty, what aspect do you feel guilty for? Why do you feel so shameful? These help us get them talking about their own stuck points. When we educate patients around PTSD symptoms, we want to make sure that we're talking about the 4 symptom clusters of PTSD as outlined in the DSM. This first one is intrusions. So this is thoughts about what happened, memories about what happened, all the re-experiencing symptoms. This can also be nightmares that pop in whenever they fall asleep. The second symptom cluster is hyperarousal. So that's sympathetic nervous system arousal and limbic system arousal. So when they get reminded of the event, Their nervous system lights up, their heart rate increases, they have difficulty breathing, they can have anxiety and panic-like symptoms, they can't sleep. All of this, the physiology that gets activated by the memories and the intrusions and the re-experiencing, that falls into symptom cluster number. The third symptom cluster is changes in the way that somebody thinks about themselves, other people in the world, that maintains symptoms. These are these maladaptive cognitions, and also changes in mood in the way that they feel. This makes a lot of sense because if somebody's having these re-experiencing symptoms, getting reminded of the event, and then their physiology is reacting in the anxiety stress response way, then over time, that's really going to wear the system down, and they have depression and different views about themselves and the world that keep them even more stuck. And the last symptom cluster that is a very important one is avoidance. We can avoid thoughts, feelings about the event. We can also avoid people, place, and things that remind us of what happened. Avoidance can be huge. And a lot of times patients don't even realize how they've structured their life with such high levels of avoidance that's actually maintaining their symptoms. And so when we have PTSD, the whole symptom cluster is separate with avoidance here because high levels of avoidance maintain all of these. Just by coming to therapy, a patient is decreasing their avoidance. And I always like to remind them of that because they're already doing the work. That's also why coming to a therapy appointment is not fun. Patients want to avoid it. Patients want to cancel it. And I normalize that as well and just let them know that as soon as they come to therapy, they're already decreasing their avoidance skills. So if their other symptoms go up because they're not avoiding, that's normal. And that means we're doing the work.